First of all, we're going to hear from Dr. Pat Grady. She's with NINR and NINR has been designated as the primary research entity on palliative care by NIH. I think when I sent out the notice in a revision, this kind of came from Kathy's staff, that maybe it was a good idea to give Dr. Grady a call and see if she was willing to join us. I must have got 6 or 7 emails from you guys coming saying, good call, good catch. So we're very delighted to have her with us today, and she's got a very limited time that she can speak, but hopefully with good news for all of us. So Pat, will you come forward?
Well, good afternoon, everyone. I am really very excited to be here, and I'm grateful for the invitation from Assistant Secretary Greenlee and all of her staff, as well as the center's leadership, Myra Christopher, Kathy Foley, and John Carney, to help to bring me here today. I appreciate the ability to talk to you a little bit about the research that we're doing. The bottom line is we've learned a number of things, but there's a great deal more to do. But we have people who are prepared to do it, and we have guideposts along the way from the scientists who are, and clinicians and people like yourselves who are helping us to identify what the important areas are to study. So just recapping, we've heard discussions today about addressing chronic pain, models of care, advanced care planning, and palliative care. For each of these areas, the underlying theme that I'm hearing from my ears is that many of these areas really need to be and must be informed by research and data that will help us to support the directions that we say we need to go and to support the changes that we say need to be done in the system. And research is something that allows us to identify the gaps and also to be able to document and justify the decisions that we make regarding best care and best practices, and particularly palliative care, which is still very much an area that in which a limited amount of work has been done up to this point. Now, in addition to our long-standing history in the area of end-of-life and palliative care, we also support work in the areas of related to palliative care. So even if it isn't labeled palliative care, some of the symptom science and support studies that we support are related, such as self-management, also mentioned today. And we also, how we got into this area and legitimized our ability to be able to address palliative care and end of life was because of our long history in pain research. And so that is very much a part of our program. It's not, a single approach or anything that was suggested earlier, but it is very much a part of the program. So 4 messages I want to convey to you today. Very basic messages, one of which we do support research in palliative care, end of life. We are the major supporter, but we have other partners on campus, across the campus, and also now across the department and other agencies. We also are committed to building the science of palliative care across the lifespan and across settings. We continue to address contemporary issues in palliative care, and I'll speak about that a little bit in an area, so in a moment, so that we're not simply addressing the traditional areas, but we're trying to move into some of the more recently identified areas that are important. We also move this science forward collaboratively, and I'm hesitant to use the word interdisciplinary now after the discussion this morning, but it also involves partnerships of all kinds. So the first of these main points, supporting research in end-of-life palliative care. I'll share with you just an overview of some of the programs. I can't cover all of it, but just to hit the highlights for you. As was mentioned by John just a few moments ago, we were designated the lead institute for end-of-life care on the NIH campus. And that, in the number of years since that has happened, we have invested over $100 million in that area. We've also been joined by other institutes across NIH, primarily National Institute on Aging and the National Cancer Institute, as well as other partners such as AHRQ and now other partners throughout the department. But suffice to say that although we are not the largest entity on campus, but approximately 18% of our budget is dedicated to end-of-life palliative care. So as the science develops, we recognize the importance of not only developing the science, but also developing the infrastructure, and we're working on that as well. So we have supportive research grants. We have opportunities for collaborative activity. We also have a consortium of interdisciplinary research that we have formulated. And we now have a specific office that represents the research, but also has an arm that enables us to identify some of the other areas that we need to deal with that are a little more policy related. We're not a policy organization, but things related to informed consent and those kinds of things, and the ethics which were mentioned earlier. So we have formally established that Office of End-of-Life and Palliative Care Research. So at NIH, there is an emphasis on building research programs that will bring interdisciplinary groups of scientists together. And we believe that palliative care and end-of-life is an area that really requires that kind of approach. It is, by its nature, one of the more interdisciplinary areas, as also is pain. And so these are very complementary in that regard. We also, in fact, the issue of chronic pain that we discussed earlier really does speak to the fact that this is an integral part of end of life and really should not be considered as a separate area, at least from our perspective. That's how we have been operating and plan to continue to. So in addition to the deliberate steps that we've taken to ensure that the results of the research is being done and that it's a high quality, we also are taking steps to ensure that the research is disseminated and that it is communicated to the public. And you all, many of you have been very personally, as well as organizationally, helpful in that. And some quick examples include our palliative care brochure available online that's over nearly 2.5 million downloads in English and about close to 500,000 downloads in Spanish. The recent review that was published, that is published online, Building Momentum, the Science of End-of-Life and Palliative Care, is a document which summarizes the last 14 years of activities, of research activities and organizational activities. And that is available online. And that, just in the short period of time that has been online, has been downloaded many thousands of times. The other thing that we do have for the public are fact sheets that convey in plain language the results of the research and also some of the tools that have been developed. We have tools such as the communication model that Randy Curtis has used on the West Coast that has been very successful, and others that are available online. We've also just recently partnered with National Institute on Aging, and they're a very well respected and well-known senior health series. We have collaborated to provide a chapter or module, as they call them, on end-of-life care, and that is to be released in February. So it's not quite on the website yet, but that will be released in February. So we're committed to building the science, but we're also committed to getting that science out and disseminated to the public so that it can be used. I don't know how we're doing, Keela, in less than 15 years, but I can guarantee that there are at least a couple of things that have made it out in a much faster than 15 years. That's one of the advantages of the work that we do and the work that other clinicians do. If you're really close to the patient groups when you get the ideas for the studies and design the studies, typically you're much closer to implementing and disseminating them than if you develop them somewhere a little further away. With regard to building the science, we have a number of program announcements and requests for applications that have gone out over the last year and are still active. We've partnered with NCI, a strong partner, and also NCAM to support the National Institute on Aging's idea of advancing the science of geriatric palliative care. This is something that we have focused on previously, but focusing with them. Part of our job on campus is not only to be the point for end-of-life and palliative care, but also to lure other partners, or involve other people. So we are increasingly successful at that. We also have a program announcement that is just recently been released on building evidence and effective palliative care and end-of-life interventions, which really is another push to get studies to look at interventions that work, taking interventions that are out there and testing them on specific populations, clinical studies, clinical trials, if you will, or to devise new ones and test them. So we have just made another push on models of care, measurable outcomes to try to get increased focus on it. Focusing on the other end of the lifespan, which we haven't talked too much about today, we also have focused efforts just increasingly over the last year and a half on advancing palliative care research for children facing life-limiting conditions. As you all know, this is an area which is extremely critical, it's important, and yet it's an area that there is almost an aversion to dealing with because it's so difficult and it's so hard to deal with it. There are not a lot of approaches for doing that. So we have taken that on because it is a gap in the science and it's a gap in the care. So we've just launched a new campaign that's called Palliative Care Conversations Matter. And this is designed to increase the use of palliative care in children. And so it is designed, it's aimed at healthcare providers and also families, children and families with life-limiting illness. And so there are a number of tools that will be on the website for use and for availability to for both the caregivers and for the families to use. So those are some of the recent things that we have done. We also, I won't address the advanced care planning because you all have mentioned that this morning, but much of the research in that area, the POLST, Hickman and others, has been funded by us and is still, we're working with the implementation of that. So that's an important area for advanced directives. We're also very involved in the geriatric palliative care settings of care. Dr. Tenno and her colleagues have contributed a great deal in that area and continue to do so. Other of our scientists are looking at, in fact, Drs. Carlson, Morrison, and some others here, looking at fostering better knowledge of the systems and of care and types of service received in hospice. So we're focusing on the hospice arm of it, and also other forms of care delivery in other settings. I've spoken about pain, but there are other symptoms accompanying serious life-limiting illnesses that we're funding studies on symptom management for, and some of those include fever, diarrhea, constipation, fatigue, a great deal of work going on that. And so those are areas that we're also focusing on in general, but specifically palliative and care and end of life. So we expect that information will help to move us forward. We also, areas of decision making, when we look forward to what needs to be done, research and decision making, how these decisions are made. Several of you mentioned that this morning. We're moving forward on that. Effective models of care, I'm very interested to hear what the discussion is this afternoon. Caregiver health is another area that we have a strong focus on, particularly end-of-life and palliative care, although aging is part of that. But this is something and that's unique in our focus, that not so many others really focus on caregivers and their health. So again, these and other coping strategies are areas that we are either currently focusing on or moving into focusing on as we go forward. So in the summary statement, I would simply like to say in my remaining few minutes that, as we've heard today, palliative care serves a very critical role in maintaining quality of life at any stage of illness, and not only end of life, and not exclusively, but particularly in any stage where people have a serious or life-limiting illness. And part of the thrust of the pediatric campaign is that it's serious illness, and not all serious illnesses end in end of life, but palliative care can be extremely effective along that span. We have engaged the public in a number of things, such as town hall meetings, the summit that was held about 2 years ago, which many of you participated and brought it to a very high level. So again, these are things that we're engaged in. We will be as always, contacting you and getting input from you for ideas that we're not addressing, ideas that should be addressed. The latest of these is that we, in our planning, our strategic planning as we move forward, we are convening groups on identifying areas, important areas to study. What questions should we be studying? And because we understand everybody can't come to Bethesda at the drop of a hat, we also have a website specifically dedicated to this. And one of the areas we're looking at, of course, is end-of-life palliative care. So I would encourage you to look at the website and submit your ideas or your questions on that. And you'll see it's the IQ website, so you'll see it specifically will draw you to it. So we really are very keen to have you weigh in on that and to give us your opinions on that. So, I have mentioned our palliative care conversations matter pediatric campaign. I encourage you to look at the website and see what is available there. I also mentioned a little bit ago, and I want to reinforce the palliative care consortium. This consists of a network of centers around the country. It's small, and we hope growing. That will form a structure that studies can be done. This is the center for this is at Duke University, and the idea is that we have built an infrastructure, and that studies can now be done on that infrastructure. And so I encourage you to think about your ideas and to contact them. We also have a request for applications that's out for that. So, and would continue to do that. So in summary, I've described just briefly many of the end-of-life palliative care research efforts that we're engaged in to build collaborations, inform the public, translate our science into meaningful improvements in the healthcare system. So we're not. I was going to say we're not done yet, but we've barely scratched the surface in terms of what needs to be done, and look forward to continuing partnerships. And any of the, we have so many new tools at NIH. I will mention, for those of you that are curious about what are we funding where and in what parts of the country, we have a tool on the website that's called Reporter, and you can just dial that up, bring that up on the website. And there's a public version that's intended for anyone who's a scientist or not a scientist. And so you can look in there for keywords of to get what are we funding and where is it. And if you have trouble with it, just look up the abstract of someone that you know or put in the name, and then they'll hook you up to at least one or two studies, and from there you can get the keywords for that study and move it out. So we are available online or by phone at any point in time, and we really look forward to hearing from you. And I really can't speak to how excited I am, the level of excitement of seeing all of you in the room, because over time, and I think Kathy could probably speak to this too, you see like progress just so far, and then there's a little setback, and then there's more progress. But this group is not to be denied, and so I know that the goal of achieving better care at end of life and serious illnesses will be achieved. So thank you very much for your time.